Sudipta with her presentation on visual outcome post-pituitary tumor excision.
Yeah.
Good morning, everybody. Excuse me. नहीं आया. Upload preview room में.
Any other presenter is name, please?
So today I'm taking you through the visual outcome post-pituitary tumor excision. Now in neuro-ophthalmology, you always have to be in combination with your neurologist or a neurosurgeon so that the vision that is there in the patient is always restored. Because per se, as being an ophthalmologist, we can't do much about the brain. All we can do is a placebo treatment for such patients. Just taking you through the brief anatomy. As we all know, the pituitary gland is situated next to the cavernous sinus where all the cranial nerves are located, which aid to the ophthalmology thing. Coming back to the brief history of pituitary tumors, is one of the most benign tumor in the central nervous system. The incidence of pituitary adenoma varies from 3% to 25%, and it can be categorized into the functional, which leads to the hormonal disturbance, or the non-functional tumors which has no hormonal disturbances. Diagnosis: variable history depending on the functional status of the tumor, its size, and whether it has any mass effect. Most ophthalmologic complaints are secondary to the mass effect caused by the macroadenomas. Together, many of these symptoms form the so-called chiasmal syndrome, which applies to any compressive lesion of the chiasma. Now coming to the brief signs and symptoms, headache, we all know it could be related to some kind of neuro-ophthalmology complaint. Decreased vision. In decreased vision, it is usually loss of the peripheral vision, or it can be loss of depth perception. Coming to the loss of peripheral vision, it can be either unilateral or bilateral optic neuropathy. The visual acuity may or may not be involved in these cases because usually the central island is usually spared. Coming to the loss of depth perception, which is stereopsis, some patients will complain of with complete bilateral hemianopsia, will complain of a complete loss of the depth perception, especially in patients who would try to cut their nails or try do some near work. They will complain of the loss of depth perception. This has been termed as the post-fixational blindness, and it is caused by the two blind temporal hemifields overlapping during the convergence. Diplopia is one of the main important signs that is seen, symptoms that is seen. Parotic diplopia from oculomotor cranial nerves, example the 3rd, 4th and the 6th paresis, from lateral extension of the tumors into the cavernous sinus, or a non-parotic diplopia as a result of the hemifield slide, result of the loss of physiologic linkage between the two functional hemifields. Diplopia may be present constantly or intermittently, which varies from patient to patient and depending on the kind of the pituitary tumor that is present. Visual field defects, as we are all aware, tumor compression on the optic nerve or chiasma leading to axonal damage. The severity and the symmetry of the visual field defect may vary from patient to patient. So coming to the brief various visual field defects that we usually come across, it could be either bitemporal hemianopsia, which is the most common, cecocentral scotoma, homonymous hemianopsia, junctional scotoma, or monoocular visual field deficit of the junctional scotoma of the truncaire. Now not coming into the description per se, and just to tell you about the compression side, in the first one it is usually in the optic chiasma region. The centrocecal scotoma is the compression of the macular fibers on the posterior of the chiasma. Homonymous hemianopsia is usually at the optic tract. Junctional scotoma is the ipsilateral optic nerve and the Wilbran's knee of chiasma, whereas the monoocular visual field defects is the ipsilateral optic nerve before the chiasma, before it enters into the chiasma. So the other signs or symptoms that can be present, the patient may complain of pain in the face or sometimes including the sinus pain or ear pain. There could be a drooping eyelid. Seizures may or may not be present, and it may be associated with nausea or vomiting if the intracranial tension in the brain is increased. Optic atrophy is the last thing that we come across in these patients, where the patient is gone undetected of having a pituitary tumor in the brain or having a compressive effect in the brain that can lead to optic atrophy. So the chronic tumor compression can lead to optic atrophy, and some of the atrophy is reported to be present in approximately 50% of the pituitary lesions with visual field defects, often described as the bow tie or man-shaped pattern in the both eyes. Visual field testing is very important in such patients. In fact, any patient reporting to you with a headache, you need to get a visual field testing done so that the picture, initial picture of the brain or the any kind of neurological problem can be detected. Management, of course, comes into surgery. Pituitary adenoma can be either debulked or there could be partial excision depending on the discretion of the neurosurgeon as to which would be better for the patient, and is often carried out via the transfrontal or transsphenoidal or transterritorial approach. Endoscopic techniques have improved visualization of the tumor and allowed for smaller incisions and faster healing. Now, this is the most important slide, the predictive factors for post-operative visual outcome in pituitary tumors. A shorter duration of the symptoms before surgery can recover the vision completely. A younger age are associated with a higher amount of resolved nerve fiber layers. Additionally, large tumor size and supracell extension are significantly associated with poor post-operative visual outcome. And regarding the prognosis of the visual field, favorable outcomes are observed in patients with a short duration of symptoms, a higher pre-operative visual field, and a thicker peripapillary temporal retinal nerve fiber layer. Just skipping in, just a few of the images. As you can see, the pituitary tumors are lying there. These are the few of the visual field defects which was before surgery, and post surgery we can see a contrast in the visual field and improve in the vision. Thank you so much everybody for your patient hearing.
Anything you want to add?
Very nice presentation, Dr. Sudipta. So, one thing, because there may be variable presentation, and as you have told that earlier presentation can lead to better visual outcomes. So the visual fields, even if the patients present like with complaints in only one eye, the visual fields, the neurological should always be done for both the eyes, not to miss the subtle findings, like sometimes you find a supratemporal small area in the other eye, though the patient doesn't have anything there, any complaint in that eye. So neurological fields, bilateral, always in all the patients, irrespective of whether the patient is having any complaint in that eye or not.
Sometimes the visual fields gives us an incidental finding of a patient having a pituitary adenoma or a pituitary tumor in the brain. Thank you so much. Thank you. Absolutely. Absolutely. Sometimes patients go undetected. Even though they report to our hospital, there are no proper signs or symptoms. Sometimes subtle.
Study on it, and you do a OCT that gives you a substyle thing, the temporal field goes early in those cases. So that also, suppose your visual field you are not able to do, OCT everyone has it and can do it, that gives you also a click. So, but what I wanted to say, that the vision recovery, if you see that the OCT findings are very early in these cases and it is correlating with your visual field, and the earlier you are taking up,
Correct.
yes, the visual prognosis is good, but
Yes,
you
if it
see,
is delayed, yes.
because some of the patients come with a visual acuity of say hand movement, you cannot do a visual field in those cases.
Absolutely.
So the thing is, it's not that they don't recover. You have to follow these cases for 2 years, then only you can say. Because 6 months, if you do post-surgery and you follow them up, some recovery is still there.
Some recovery is definitely
So that
there.
is the thing.
Actually,
and,
in these
because-
cases, it's a long-term recovery for
yeah,
these patients.
so-
Usually, I prefer to give them some kind of neuroprotective drug in these patients, so that in case, in a sort of brinzolamide or any kind of dorzolamide, just to make sure that the IOP fluctuation throughout the day which we have diurnal variation is kept under control, because whatever may it be, the compression effect of the tumor is there, and along with that the intraocular pressure that is also there. At least we can keep the intraocular pressure under control, and the fluctuations can be taken care of, and then probably follow up them in the longer period. Anyways, they will be coming to the neurosurgeons for follow-up. They are usually toppled into our OPD, and so the visual, we can see the recovery in the
So
visual
actually
fields.
the neurosurgeons has to be made aware, because
yes.
the thing is they have to collaborate, they have to send the patients. Any pituitary adenoma, if you don't follow up them for 2 years, actually you cannot predict what exactly are the poor
outcome
diagnosed
is.
outcomes for these cases. There is a recovery of the axonal flow that they are talking about, and more work is going on in it. So at present actually we are just talking on these things, we cannot still predict. So if you do a 6-month study or a thing, it's quite
does-
less. So that is the thing.
A longer period of study is definitely
Follow-up
required.
is also required, because we have to take care of any possibility of recurrence.
Yeah.
Because
Absolutely.
it's very important. Visual outcome has to be seen, visual field charting and perimetry has to be done regularly on a yearly basis, even for 2 to 3 years. But then another thing which is recommended by the neurosurgeons is also that there may be a recurrence, so that is also important to be considered.
In fact, in those half excisional tumors,
Yes.
in fact, in just those who are doing
There are some-
debulking,
yes.
they can come
They
back.
expect that there are some subclinical levels of tumor may be remaining, which may recur. So in that case, visual field charting is very important. It's very useful.
Just to be more specific, we are looking at the macular GCC. Is that what you should look at? Where you get the nasal thinning, and that is exactly what you get on the visual pathway. So it's the pre-perimetric detection of your pituitary tumor. So when you have a bitemporal, you know there's already a functional defect. But if you want to pick up the structural, do the macular GCC, and if you notice nasal thinning in that, you know this patient is going to be prone, even if you have normal fields. In which case, you can tell there is some amount of compression already on the pathways, so might as well go ahead with the surgery. So you can guide your neurosurgeons. But once your macular GCC is completely thinned out, then there is no sense following it up on that.
Correct. Thank you so much. Thank you.
Thank you.
Adenoma, they are followed up in endocrinology, and many a time, because when it is not more than 10 millimeter, they are not going to do anything, they are just following it up. So in that cases also, these early changes, they can be useful, because the perimetry, many a time they send the patient for the perimetry, the endocrinologist, or their pituitary macroadenoma or the microadenoma, whether it is increasing or not.
Okay, so earlier is always the better, be it the patient's presentation, the diagnosis, the treatment, and yes, the follow-ups, the importance cannot be underemphasized. Okay, so thank